Hello, my name is Brittney Murray. I'm a clinical cardiovascular genetic counselor at Johns Hopkins Hospital in Baltimore, Maryland, and I'm going to be taking you through an introduction to cardiovascular genetics today. This is a little bit about me. I'm not going to read this to you, but in brief, I'm a clinical genetic counselor at the Center for Inherited Heart Disease at Johns Hopkins Hospital, and I'm also the clinical genetic counselor in the ARVOYC program at Johns Hopkins, which is a large clinical and research center developed specifically to the rare cardiomyopathy ARVC. I'm also active in both the Hopkins and University of Maryland genetic counseling programs as a supervisor, but also developing their cardiovascular genetics curriculum. And I'm the current co-chair of the National Society of Cardiovascular Genetic Counselors within our National Genetic Counselor organization. Therefore, I'm involved both at the local and the national level and passionate about inherited cardiovascular disease. This webinar series is very timely because it is increasingly recognized that the genetic evaluation of patients with channelopathies and cardiomyopathies is very important to their overall care. This recommendation has been detailed in practice guidelines, such as this one that was recently released in 2011 from the Heart Rhythm Society and the European Heart Rhythm Society, recommending genetic testing for channelopathies and cardiomyopathies. However, they do indicate that genetic testing should not just be viewed as a blood test. It is just one component of an entire comprehensive cardiogenetic evaluation. So this needs to include an expert assessment of the proband's diagnosis and a discussion with them about the probabilistic nature of genetic testing, and this should include extensive pre-test counseling, because there is a lot of uncertainty that surrounds genetic testing as well. And this is in the context of both their personal history, but also in the context of their family history. Today, we know that cardiovascular genetics is expanding rapidly within the field of cardiology. It is now including a wide ranges of diseases such as congenital heart disease, coronary artery disease even, which we previously had thought was largely an environmental component. We know now that familial hypercholesterolemia, it has a large genetic component. There are syndromic causes such as muscular dystrophy and heart disease and aneurysms, both thoracic and abdominal, which can be syndromic and non-syndromic. Thrombophilias, valvular disease, and then also the arrhythmia syndromes such as AFib, Brugada syndrome, CPVT, long QT, and short QT all have a genetic component. Cardiac amyloidosis is another multi-system disease that is also thought to be genetic. And then the cardiomyopathies, ARVC, DCM, HCM, LVNC, and restrictive cardiomyopathy all have large genetic components. In this webinar series, we're going to cover the cardiomyopathies, including HCM, DCM, ARVC, and LVNC, the inherited arrhythmias, including long QT, Brugada, and CPVT, and the aortopathies, including Loeys-Dietz syndrome, Marfan syndrome, and other aortic disorder syndrome. There will be a series on familial hypercholesterolemia as well, and then followed up with an explanation of what to do with results and how to interpret them in the care of your patient. But first, we're going to talk about the why. What is the utility of genetic testing, and why is it important in the care of today's cardiac patient? First and foremost, this will help with an accurate diagnosis. Then it helps in terms of some of the management of that patient sitting in front of you, the proband and the family. Then once a genetic component to cardiovascular disease is recognized, this can help with at-risk family screening, including recognition of occult disease, prevention of sudden death, and in some cases, prophylactic treatment. And where this field is moving is that there may be other options for your patient in terms of possible prenatal planning for those who are severely affected by cardiovascular disease in their family. We'll start with an accurate diagnosis. Prior to the availability of genetic testing, there was really little available for the confirmation of a diagnosis other than some molecular and pathology findings. most diagnoses were based on clinical criteria alone. Therefore, unusual presentations and early disease were very often missed, and there was no way to diagnose preclinical disease. This may have a lot of implications for the patient you're taking care of. This is a case example from a young woman, you'll see this woman circled here, who has showed up to the cardiovascular clinic with an increasing shortness of breath and exertional dyspnea, and she was found to have a borderline ejection fraction. She was told at first that her disease was likely viral and given an ACE inhibitor, and told to decrease her exercise. However, as part of this, she was recommended to have a cardiogenetic evaluation, where she came to our clinic and we drew this family history. This is called a pedigree in genetics, how we map out the family. And she was identified to have a very strong family history of both sudden death and heart failure, including her mother, who died of heart failure at age 37, multiple family members who died suddenly, a cousin who had a heart transplant and then later died at 25. This indicated to us that there was clearly something genetic contributing to heart disease in her family. With the combination of arrhythmias, sudden death, conduction disease, and cardiomyopathy, we suspected that there may be a Lamin mutation in this family, and it was identified that she carried a Lamin frame shift mutation. This then had many further implications for her care, in that even though she only had a borderline ejection fraction, we knew she was at a high risk of sudden death, so she received a prophylactic ICD and is managed much more carefully. This will then also have much future implications for both her daughter and her cousins who are yet diagnosed, because they're going to be now managed appropriately going forward. This case example really shows that genetic testing may help you in the appropriate management of the patient sitting in front of you. A lot of genetic risk factors indicate a higher risk of sudden death than based on either symptoms or cardiac testing alone. So this can often lead to prophylactic ICDs and in some cases prophylactic medication. This may also have implications for medication use or avoidance. For example, in the channelopathies, there are many specific drug recommendations that patients should be on, and there are many drugs that they should avoid, many of which are very common drugs that may be used in a variety of settings. There is an entire website, crediblemeds.org, which is dedicated to listing all of the drugs that patients with inherited channelopathies should avoid. Where cardiovascular genetics is going in the future is that knowing the genetic underpinning of a disease may open doors for targeted therapies. Currently, there are clinical trials going on for sarcomere mutation carriers for a drug which may mitigate many of the progression of their disease. And there are clinical trials for Lamin mutation carriers as well. Additionally, PCSK9 inhibitors have been shown to possibly be targeted therapies for patients with cardiac amyloidosis. This field will only be expanding going forward as we learn more about the pathways underlying these genetic cardiac diseases. Once you have established that there is an inherited cardiac disease running in your family, the family of the patient in front of you, this then implicates that this is something that is inherited and therefore other family members may be at risk. Most of the inherited cardiac conditions are inherited in an autosomal dominant manner. Autosomal dominant meaning, in this figure to the right, that this man only carries a non-working allele on one of his two alleles, so he has a mutation in one copy. However, he is still affected. His partner has two working copies. Therefore, in all of his offspring, they have a 50-50 risk to inherit either his working allele or his non-working allele. Therefore, it is 50-50 whether he passes on this risk factor to his children. This is 50-50 with each pregnancy. I have plenty of families that have all children who all inherited their risk factor, and some who none of them inherited the risk factor. It's a flip of a coin with every pregnancy.
Therefore, because this is on one of his autosomes, meaning not his not his sex chromosomes, that means there is no difference in inheritance risk by gender. There'll be plenty of families that tell you that only the men in their family develop disease. This is unlikely to be truly the case, that it may be that only the men are affected with disease. However, we know that these risk factors can be passed to either gender in most of the cases in cardiovascular genetics, and that all first-degree family members are at 50% risk to have inherited the same risk factor. And this 50% risk is passed on with each pregnancy. Once you know a mutation in a family, then you can identify and screen family members with Cascade Screening. You want to test first the most clinically affected person in the family. This is the person with the severest phenotype in whom you're most likely to find the genetic component of this disease. Hopefully, you'll find a known pathogenic mutation, then can test unaffected family members, and the positive ones can have counseling and further clinical surveillance, and the negative ones can be released from further screening. Likely pathogenic mutations indicate that there is not as much clinical and research evidence behind that mutation. However, therefore you may want to segregate this in your family members and hopefully confirm its pathogenicity. The downside of cardiac genetics in many cases is that you may find a variant of uncertain significance or a negative result. If you have an affected individual, and especially if it's a disease with a known large genetic component, it is unlikely that a negative result rules out that disease in them. For example, in long QT syndrome, if they do not have a known mutation identified, that does not mean they don't have long QT syndrome, and unfortunately does not mean that their family members are not at risk. Therefore, most of the time, all unaffected family members still need screening. As we talked about in the beginning of this introduction, guidelines have been published which indicate that cardiovascular genetic testing is indicated in many cases. They've divided these recommendations into Class 1, which is recommended, Class 2A and 2B, which can be useful or may be considered, and then Class 3, which we're not going to discuss, is when it's not recommended. For Class 1 indications for cardiovascular genetic testing, this means the diagnostic yield is over 40%. There's a low variant of uncertain significance rate. This genetic testing may give diagnostic and prognostic information, as we discussed above, and the results could influence therapeutic choices. This Class 1 indication includes patients with hypertrophic cardiomyopathy, patients with DCM and conduction disease, patients with DCM and a history of premature sudden death, patients with long QT syndrome, and patients in which you're suspicious of CPVT. The other conditions we discussed at the beginning of this webinar, most of them fall into the Class 2A and 2B recommendation. When you're able to have a patient in front of you, this graphic really describes how you can move forward with cascade testing in the family. So hopefully, such as in this family, you have a hypertrophic cardiomyopathy patient that had a mutation identified. You can then test their first-degree family members and identify who also carries the same risk allele. You then only need to test the children of positive patients. This helps you quickly identify the other family members who are at risk and can decrease cost both of genetic testing and of repeated cardiac screening. This is a case example from my clinic, which really indicates the importance of cascade screening in a family. This is a gentleman who in his 50s was diagnosed with arrhythmogenic right ventricular cardiomyopathy and found to have a pathogenic PKP2 mutation. He was managed appropriately, however, he never finished cascade screening within his family. Unfortunately, just a few years later, his niece, who had not had any screening, died suddenly on the soccer field at age 16. That really led the rest of his immediate family members to start having clinical screening. Unfortunately, cascade screening did not extend to his other relatives, and again, just a few years later, and this is a true story from my clinic, one of his cousins had a sudden cardiac arrest at age 47. Fortunately, he was able to be revived.
He was found to carry the same pathogenic PKP2 mutation that our proband carried. Then the family really got the message, and other people in this side of the family continued screening, and his sister was found to have the same PKP2 mutation, and on screening, it was actually clear that she had occult disease, and she got a prophylactic defibrillator. This sister was found to not carry the mutation in the family, so then it was actually very useful information to her two sons that she could not pass on what she did not have. Therefore, it was unlikely that they were at risk to develop ARVC in this family. Therefore, complete cascade screening in families with genetic cardiovascular disease literally can be a life or death situation. Beyond just identifying who is at risk, we know that early identification of those with inherited risk for cardiovascular disease can lead to improved outcomes. For example, those at arrhythmic risk may be placed on beta blockers prophylactically, avoiding symptoms, and beta blockers have been shown to reduce risk of sudden cardiac death. In ARVC, which is my bias, as we've talked about before, there is increasing evidence that reduction in exercise in mutation carriers, even if they have no evidence of disease, reduction of exercise may avoid disease progression or disease presentation at all. Of course, a reduction in ejection fraction that is minimal is much more easily managed than advanced heart failure. And in every disease, a large percentage may be asymptomatic and have occult disease, and unfortunately, sudden cardiac death may be the first symptom in almost every disease that we'll talk about throughout this webinar. In the future, for your patient and their family members, prenatal options may be available when we've identified a genetic risk factor in a family. Insurance companies are increasingly covering in vitro fertilization and the accompanying pre-implantation genetic diagnosis. This is when families have fertilized embryos tested and only re-implant the embryos that do not carry the known genetic mutation in the family. They may choose to undergo this to avoid future generations being impacted by the disease that runs in their family. This is, however, very complex counseling, as many of these conditions are adult onset and most of them are compatible with a high quality of life, and they have reduced penetrance and variable expressivity. Therefore, the ethical concerns around this type of testing are complex and should be discussed extensively with your patient. This leads into that genetic counseling is an important component of genetic testing in the cardiovascular diseases. Most guidelines, both by the HRS, EHRA, and the American Heart Association, all recommend genetic counseling prior and after testing by a trained professional. You can find a trained professional by going to findageneticcounselor.com, which is a list of all the genetic counselors in the country that are part of the National Society of Genetic Counselors, which is our overarching umbrella organization. As I said at the beginning, there is a specific cardiac section of this group, and there are counselors trained specifically in cardiovascular disease, although all genetic counselors are trained at some point in their training in all genetic diseases. There are also some companies that offer telephone genetic counseling, especially to more remote areas and areas where there are not a genetic counselor in their area, and this has really improved access to genetic counseling. We know that these inherited cardiovascular diseases and the entire genetic testing process can be anxiety-producing and produce a lot of worry in patients and families. However, we know that patients that have genetic testing as part of a specialized genetic counseling clinic and with extensive pre- and post-test counseling have been found in multiple studies to have no change in quality of life, either in the patient diagnosed or their family members. And then in those cases, they do not have a change in distress based on a positive genetic test result. Disease-related anxiety in carriers does remain somewhat elevated, but does not increase beyond distress related to the clinic visit. Also, as could be expected, non-carriers have significant anxiety reductions. This is all in patients who have received specialized genetic counseling. So when should you refer to a genetic counselor? Ideally, in a perfect world, the genetic counselor would handle both the pre and post-test counseling. We understand, however, this is not always feasible. So therefore, it's important for you to know that genetic counselors also accept post-test referrals. Therefore, if you have a patient who's positive, it's important that we may counsel regarding the implications of this test result for that person, and then start that important Cascade family screening. If a patient comes back with a variant of uncertain significance, one of these gray zone results, we may provide advanced research into this variant and help identify whether it is leaning towards pathogenic or not, and we may be able to handle that family segregation, which may lead evidence to reclassifying this variant. Even a negative test result would be appropriate for a referral to a genetic counselor. In many cases, there are additional genetic testing options beyond basic panels that we may be able to discuss with your patient. And in all cases, even when a patient is only considering genetic counseling, and in any of these three scenarios, we can counsel regarding adjustment, post-traumatic stress, anxiety, and help them with how to disclose this result to their family and children. Therefore, I hope that I've gone through a short summary of the different conditions that will be handled in more detail in this webinar, and I've hoped that I have expressed to you the importance of a genetic evaluation in cardiovascular disease today.